Good. All the answers are going to be in the lecture, so don't stress. Good. Excellent. Good. Okay, Noor, you've been reading. All right, okay. So now let me get to the PowerPoint. Which is the one that plays the... Oh, there. Come on. It looks different on all the screens. Okay, so we're going to talk about evaluation of acute abdominal pain in the pregnant patient. So rapid diagnosis is required to prevent, normally we're worried about the patient, but now we've got another patient. So we have to worry about making this diagnosis rapidly with the lowest possible risk, and we've got to worry about the fetus. Acute inflammatory processes can result in preterm labor, which then can result in either a dead infant or an infant that requires significant care and is going to have significant morbidity throughout their life from prematurity and fetal neonatal loss. Okay, additional risks are present in this population. So how can we make a definitive diagnosis that we can act on while minimizing the risk? So first of all, whenever you're looking at studies, you need to have in your mind what, when you see abdominal pain, when you see a CT, abdominal pain, MR, abdominal pain, so you're dealing with an acute abdomen. So you need to have in your mind for the age group that you're looking at, what are the most common things? Because you're going to want to start there first, okay? And that goes not just for what we're talking about today, but for any patient. If you're looking at a patient who's 80 years old and they fell and they have back pain, what's the first thing that you should think? Right. Okay, so this works for everything that y'all are looking at on call or during the day. Have in your mind what are the most common things. And so with acute abdomen, we've got to divide these patients into 3 different categories. The people that need to go to the OR, the people that are going to get admitted upstairs and treated medically, and then the people that just require supportive care and it's a self-limited condition that will take care of itself. Okay, so this was the original, when you hear horse beats, don't think zebras. This guy was a philosopher in the 14th century, and he basically said the simplest explanation for something is usually the best. So in acute abdominal pain, the most common cause that's going to require surgery in a pregnant lady is acute appendicitis. So when you see this study come over with a pregnant patient, abdominal pain, that's the first thing that you should think of. That's the first thing that you should try to exclude. So if you can exclude it, then you can move on to the list of other things that it can be. But this is the first thing that we need to worry about. And it's a diagnostic challenge in the pregnant patient for a number of different reasons. There are things that are different about a pregnant lady's physiology, and there are things that are different about her anatomy. And both of those are going to make the clinical diagnosis of appendicitis, which is already difficult, much harder. So before the advent of CT, there was a 20% negative appendectomy rate that was acceptable. And what that meant is the evaluation of appendicitis was confusing enough in a non-pregnant patient that if you took 20% of the patients to the OR and had a negative appendix, you were still considered to be doing a good job as a general surgeon. With CT, it's much lower because we can give them better information. But that's just to illustrate the point that this is not an easy diagnosis to make, and it's confounded in the pregnant patient. Okay, so the things that confound the diagnosis, most pregnant women have a mildly elevated white count, so that's not going to help you. A lot of them have nausea and vomiting. Most of them have at least mild hydronephrosis. The cecum in the second and third trimesters is not in its normal location. As the uterus grows from being a pelvic organ to becoming an abdominal organ, it's displacing all that bowel. So things are moving, they're in different places. The gravid uterus masks the diagnosis of peritonitis because it lifts the abdominal wall away from the intra-abdominal contents. So that's one of the things that surgeons can really use to determine if somebody really needs to go to the OR is rebound tenderness, peritoneal signs. So we lose that. And increased blood volume in a young patient can mask significant sepsis until very late. So she may not be tachycardic. She may not be dropping her blood pressure. She has a white count. She's got hydronephrosis. You don't know if she has peritoneal signs. Very confusing clinical picture. Okay, so MR is the first line test for evaluation of the acute abdomen in pregnancy. And this was presented in 2013 at Rink and Ray. In MR, we see 80% of the appendix. And in ultrasound, in a pregnant patient, we only see it about 7% of the time. Why? Because in a pregnant patient, it's usually behind the gravid uterus. So you can't feel for it, you can't see it with ultrasound, you don't want to CT the baby. So this is a good way to get a good look at the appendix. And I just made a notation on here. You can see this patient has mild physiologic hydronephrosis. And we'll go over later how we can decide if it's mild obstructive or if it's physiologic. Okay, please be aware that the people in the ER are getting monitored. And one of the things, we get monitored on our turnaround time, how long it takes us to dictate and sign. One of the things that they get monitored on is how long they have a patient in the ER. So we need to understand, that we need to, if it's going to take us longer to get this test, then we're going to have to try and be quick about getting getting the findings back to them. It's going to take us longer to get the MR than it's going to take to get the CT, so we're going to have a little less time on our end reading it if we want to help them out with their length of stay metric. And especially, it should not be left on the list till Monday because it's an MR. So MR does deposit energy into the patient in the form of heat. And the sequence that one of the sequences that we're going to use is called it, and I just want to tell the first years, this is going to sound like Martian for about a year and a half, all these different sequences. But the more times that you hear it, it will start to make some sense. Another thing that you can do to help yourself is you can go online and you can look up these sequences. They'll usually have a list of sequences, and they'll show you which sequence acronyms go with which vendor. So we've got a GE scanner here, is that correct? That's correct? So you're gonna look at the GE acronyms. And so with these gradient echo sequences, they optimize the physics of what they're doing to show you different things. So it sounds very confusing, but you can sort your way through this. So we're just gonna talk a little bit about some MR sequences just for you to get your feet wet and start kind of figuring out how to approach looking at a multi-sequence MR exam. So the single shot fast spin echo, we're going to use that because it can go through quickly and get the exam, so you don't have a lot of artifact from bowel motion because it acquires the sequence quickly. Okay, so that's an advantage. If we're looking at the appendix and we don't have a moving appendix and a moving cecum, that's going to be helpful for us. Okay, but it does deposit more radiofrequency energy. That sequence does. So that's when we're taking into account the risk and benefits, we need to understand the risks to the patient and we need to understand the benefits to the patient. You're a physician. You have to participate in helping your clinical colleagues make that risk-benefit determination. You need to understand what you're doing and why you're doing it. You are the imaging consultant. Okay, but the energy deposition is below the expected teratogenic level for the fetus. So that's something if your colleague needs to talk to a mother about this. There was some early on, probably about 10 years ago, we weren't sure if the strong magnetic fields that you applied to a first trimester fetus would affect migration. During fetal development, there's migration of certain cell pathways, and we were not completely sure that those strong magnetic fields were not going to affect that fetal migration. We sort of sorted things out a little bit later on, and we now feel that this is a reasonable risk, and the ACR says that MR is appropriate in any trimester, even the first trimester. So if you have a mom who didn't get an MR last time she was pregnant because there was some concern over these field migrations, you may be able to help your ER resident and help the mother understand that this is safe for her, that we now consider that safe. Okay, do not ever give gadolinium contrast to a patient. You guys probably remember this from fetal embryology. It crosses across the placenta. It goes into the fetus. The fetus metabolizes it and excretes it. But it doesn't excrete it into a toilet. It excretes it into the amniotic fluid. And you remember that's how the lungs develop. They breathe in the fluid and they re-excrete it back. And they breathe it in and they re-excrete it back. So if you give gadolinium to a fetus, that fetus is going to have gadolinium exposure for the remainder of the pregnancy. So it's associated with fetal loss. The lady can just lose her pregnancy. It can result in neonatal death. So after the baby's born, it will die. It can result in an NSF-like condition with contractures, and also results in some skin arthritis problems. So just don't ever do it. Okay, so when we're trying to work up an acute abdomen in a pregnant lady, these are the sequences we're going to use. The single shot fast spin echo. We get it in all three sequences. The advantage is we don't have bowel motion on that sequence, right? So we can find the appendix. So we want to find it in all three planes. We want to confirm it in all three planes to make sure that's really what we're looking at. Because we can have veins, you can have other things that sort of, terminal ileum sometimes can be really collapsed and could be mistaken for the appendix. So we look on the single shot fast spin echoes in all three planes to try and localize, that's the first step, localize the appendix. Then we look at the fat saturation. And for the first years, The advantage of a fat saturation or inversion recovery sequence is that we're suppressing the bright signal from fat. So any bright signal that's left is going to be edema. Then we look, if we think the appendix is normal, we found it, we don't see any edema around it, then we can look at the in phase and out of phase, and sometimes you'll see this blooming artifact. And this is another kind of MR thing that you'll get used to looking for. When you have two substances that have very different signals and they're right up next to each other, that creates artifacts. And we use that like on the swan sequences in the head. If there are tiny amounts of hemosiderin present, that swan sequence will really bring, we're using that artifact to help us find things that are very subtle. So we can look, because there's maybe gas in the appendix and then it's surrounded by soft tissue and they're very close together, you can get a blooming artifact there. And then we can look at time of flight, and we'll talk a little bit about that. Don't let the phrases make you, cross your eyes. We're going to use the 2D time of flight to help us differentiate the appendix from some mostly veins that could be laying around there. Okay, so this is our approach. This is our algorithmic approach. We've got the patient. We're going to look at the single shot fast spin echoes and find the appendix. We're going to figure out if the appendix is normal. If the appendix is normal, then we're going to look and see if that hydronephrosis that we see is physiologic or obstructive. If it looks like it's physiologic, normal appendix, normal kidneys, then we're going to start looking around for other things. Pyelonephritis is common in pregnant ladies. They get urinary tract infections, and you get retrograde infection of the kidney. That can result in preterm labor. Ovaries, sometimes if you have an infertility patient, you'll have hyperstimulated ovaries. Those can act as a focus for torsion. A cyst or a tumor can act as a focus for torsion. They can get cholecystitis just like any other patient. They can get pancreatitis. If they've had a prior surgery, say they've had a prior C-section or something, then they may have a band, maybe have a small bowel obstruction. Crohn's is becoming more common in the general population. And then there's some, unusual stuff that can go on with the uterus. If somebody's a VBAC patient, vaginal birth after cesarean, they can have a uterine rupture or ectopic pregnancy. So have these things in your mind. Start with the appendix, because that's going to be the most common thing that's going to be causing pain that's going to need to go to the OR. And then work your way down from there. Okay, so here are our single shot fast spin echo sequences. So we're looking at the axial. So we look at that in the axial plane. That looks like a good candidate for the appendix. And then we put our crosshairs on and we go and look at the sagittal. And that looks like it's coming off the base of the cecum, it's blind ending. So, and then we can check it in the sagittal sequence, but that looks like a good candidate. Now, we've got all this bright fat. So the next thing that we want to do is we want to go look at the fat sat. So the fat sat will make all that bright signal around that appendix go away from the fat. And if there's any bright signal left, that's abnormal. Okay, so the sequence that we use here for fast spin echo is this Fiesta. And like I said, you can go online and you can look at these sequences, which vendor, depending on which machine you're using and what it's supposed to be maximizing or optimizing for you. You may also see that FSE as TSE, turbo spin echo. Okay, so here's a normal appendix. It's coming off the medial base of the cecum. Here's terminal ileum. Here's base of the cecum. And here's this blind ending vermiform worm-like structure. Okay, so remember, as the uterus becomes an abdominal organ, it's going to move the cecum up, and the base of the appendix is going to move up with that as well. So somebody here marked this pre-surgical patient. This is McBurney's point, 2/3 of the way between the umbilicus and the anterior superior iliac spine, which is where you normally make an incision. So they marked this after imaging. This is where the appendix is in this patient. Okay, when you're looking at CT or MR, make yourself find the appendix. Even if that's not what that study's for, make yourself find the appendix. Because if you can get good at finding the appendix, then when it's a difficult case, you're going to be faster and you're going to have more confidence. You know, if somebody's breathing down your neck, some surgical resident's breathing down your neck, are you sure it's normal? Are you sure it's normal? You're going to feel more confident. Yes, I've looked at a bunch of normal appendices, and that's a normal appendix. Okay, so this is something that can help you decide where you want to start looking for the appendix in a pregnant woman. It's called the cecal tilt angle. So you go to the sagittal view, and you've got a line that kind of parallels the table. And then you have a 90-degree line. If your cecum is below the 90-degree line, then you're going to look for the appendix at about the level of the pelvic brim, about L4, about where the top of the iliac crests are. If it's above that level, if it's above the 90-degree level, you're going to look in the right upper quadrant. So here we go. This is a cecal tilt angle of 38 degrees, and there's our base of our appendix. Right there, kind of around, here's the iliac crest bilaterally, so you can see this is about the L4 level, iliac crest level. Okay, so here we are looking at our coronal, and we have a blind-ending tubular structure adjacent to the lower pole of the left kidney, or the right kidney. So this one is not fat sat because you can see the bright fat. So we go over to our axial T2 fat sat, and we look down around that blind-ending structure, and we see a bunch of edema in the soft tissues, some free fluid. So that looks like an abnormal appendix. Because we saw, once we saturated the high signal of the fat out, we see edema. Okay, so here we have fluid in the lumen of the appendix, and then periappendiceal fluid. Same patient, fluid in the appendix and periappendiceal fluid. And this is the same patient, and they had an appendicolith. And see how this is tucked up here behind this is the uterus. See how the appendix is tucked up there behind the gravid uterus? Okay, so with this fat saturation, we kind of talked about this a little bit, or inversion recovery. These are both techniques that we use to suppress fat. We use them in other parts of the body. If we're looking for infection in diabetic foot, we saturate the fat that's in the marrow. So anything that's left is abnormal edema. If we're looking for a fracture, a subtle compression fracture where we don't have any loss of the vertebral body height, we saturate the fat from the marrow, and then we see that typical band of edema under the superior end plate. Okay, so here's another fat sat sequence. So we see fluid in the appendix, and then we see periappendiceal fluid and phlegmon. When you see fluid that's kind of really in the interstices of the fat, it doesn't look like it's kind of coalescing into a collection, that can be helpful to your surgical colleagues, because sometimes they'll ask you, do you think this needs to be drained? If it looks phlegmonous, nobody's going to get anywhere draining that. You may have to wait for it to collect. So that's another thing to practice looking at. Does it look like there's something here that I could actually get out with my catheter, or if they went in to drain this? Because if it's phlegmon, it will usually respond to antibiotics. It's usually well vascularized enough. If it's walled itself off, it may not. So that's another way that you can help your surgical colleagues decide what they need to do to help the patient get better. Okay, and this is that gradient echo sequence. So this was from the quiz. So that the out of phase one, and this is the way it was explained to me, is that it looks like everything's outlined with India ink, like someone's just taken dark ink and gone all the way around the margins. So it doesn't look like you're seeing a lot of blooming artifact here between the in phase and out of phase, but that's what you would be looking for in that sequence. Okay, so blooming, like I said before, if we see hemosiderin in the brain, we'll see that blooming artifact. You can see it around vascular malformations that have bled and rebled. You can see it around calcification. You can I'm sure you guys are used to seeing that around metal when we look at MR, and you can see it around gas. Okay, so I tried to find a good picture to kind of show you, and I hope this projects well, but here we see these little collections here, and then we see them, they look more prominent on the gradient echo, so we get some blooming of that gas. That's that artifact. Does that make sense? Okay. Okay, that's just that tip. All right, so time of flight. This is going to help us differentiate vessels from the appendix. So we see a bunch of tubular structures kind of down here, and we're not really sure which one of these is the appendix, even after we've looked on other sequences. So the time of flight can help us because all of these things light up. So they're all vessels. The appendix would not light up. So this is a very rudimentary explanation of time of flight, what's going on. So when we talk about a slab, that's like a slice of the tissue. So here we have a carotid artery, and here we have, the blood flow. And this is just kind of another big tip. If we're looking at a big vessel over a long stretch, we're going to use 2D time of flight. If we're looking at small vessels and we need really exquisite spatial resolution, like say we were trying to image, a 2 or 3 millimeter aneurysm in the ACOM, we wouldn't use 2D time of flight. We don't need to cover a long area, but we need really high spatial resolution, so we'll use 3D time of flight. So what's going on with this time of flight is we apply repetitive magnetization pulses to that single slab. So I'm just talking about this slab right here. We apply repetitive magnetization. So what that does is it lines up all the protons. They all kind of respond to the magnetization field, and they all line up. Now, if we were doing just a regular, T1 or T2 weighted sequence, then we would turn the magnet off, and all of those would flip back at a rate that's consistent with what they are. So water's going to flip back faster, bone's not going to move at all, and then soft tissues are kind of intermediate. And the degree to which they flip back sort of determines what signal they send back for you to reconstruct into a picture. Does that make sense? Okay. So we apply these repetitive RF pulses to the slab. And we make the sequence that we send those pulses so fast that we don't allow those things to relax. We just keep pounding on them until they're sort of desaturated. And then if we do turn the magnet off, they don't flip right back and give us a nice signal. So all these saturated protons are going to be kind of lazy. So what's going on in this slab, you saturate the slab with repetitive pulses. Then at some point you turn it off and you listen for a signal. So what's going to happen is all of those blood protons that were saturated, as soon as you turn the signal off, they move out of the slab and new fresh protons flow into the slab. So at the time you listen, you've got all these lazy protons in the soft tissue, and you've got all these brand new, ready to go, ready to give you a great signal protons in the blood. So that's, in a nutshell, that's basically 2D time of flight. So if you're looking at the appendix, the fluid in the appendix is not going to go anywhere. So you saturate the soft tissues, the appendix, and the vein. Then you stop and listen for a signal. What's the only thing that's going to give you a signal back? The blood that's flowing in the vein. Because the new fresh protons will flow into that slab that you're listening to. Okay, so this is a picture. So all the protons that are out in this area have been saturated, and then when you finally stop your repetitive RF pulses and listen, you only hear the stuff that's moved into that slab. Okay, so we're looking at this picture again, and now we understand what we're talking about when we talk about looking for vessels with 2D time of flight. So we look at all these, and all of them over here are returning a signal. So we've saturated everything in this slab, and all of those are giving us a signal. So what does that tell us? So it's blood flow, because that's the only way you're going to get new, fresh signaling, fresh protons that are going to be able to give you a signal. Okay, so we've got several things here that are a candidate for the appendix. So we look down here, and we do the same thing. We do the 2D time of flight, and one of them lights up, and one of them doesn't. So what does that tell you? Good. Okay, so here we're going to do the cecal tilt angle again. So we're above 90 degrees. Our cecum, the base of our cecum is above 90 degrees. So where are we going to look for the appendix? Okay, so we look at the coronal, and we've got fluid in the appendix, and we've got some fluid around the appendix. So we've got acute appendicitis in the right upper quadrant. So we would be able to mark on the patient the area for the surgeon to make his incision. Okay, so this was confusing to me when I first started reading CT for appendicitis. Believe it or not, there was a time when we didn't do CT for appendicitis. But so the measurements on ultrasound are sort of specific to ultrasound. They were done in ultrasound. They're measurements that are taken when you're trying to compress the appendix. So they don't really apply to CT or ultrasound. You can have a completely normal appendix that measures like 13 millimeters. If you don't see any fluid around it, if you don't see any inflammatory change around it, size alone means nothing, unless you've got a mucocele or something. Okay. If you see fluid in the appendix, but you don't see fluid around the appendix, that is an indeterminate study. The patient will need to be admitted and watched. Okay, can't go home, needs to be admitted and watched. They can have fluid in there for two reasons. They can have fluid because they have a very early acute appendicitis, or they can have fluid in there because their appendix is communicating normally with the bowel lumen. Okay, so here is an early acute appendicitis. So here's the cecum, here's the appendix, and then you see this kind of linear area of fluid. And what that's called, so here we have the ileum, we have the cecum, and there's this thing called the mesoappendix. It's like the mesentery of the appendix. So it's where that appendicular artery comes down. So very early on, you'll see fluid that will appear in that mesoappendix, which is what gives it that linear appearance. And here I kind of put a picture of it. You can see the appendix here, and then this fatty area that supports those blood vessels that are coming in. Okay, here's acute appendicitis, a blind-ending tubular structure, fluid inside, fluid around it, more fluid around it. So we feel really confident calling that acute appendicitis. So is this the single shot fast spin echo that we're looking at, or what is this? What are we looking at?
Stir.
Right. We're looking at a stir or a fat sat. Okay, so perforated appendicitis. A pregnant patient has 2 to 3 times the risk of perforation, and perforation is associated with a 35% fetal mortality. So this is a very bad situation for everybody involved. Okay, so we see this kind of big phlegmous mass with probably an appendicolith, fluid in the appendix, fluid even out in the abdominal musculature. And there's such a large amount of fluid there that you would have to worry about a perforation. It can be tough. And we're going to talk about how diffusion-weighted imaging can help you with that. So here we have just a regular axial T2, blind-ending vermiform structure with these two low signal round. So why does an appendicolith look black on MR? Hunter. Well, what are the protons that are in, so there's calcification of fecal material. So what about the protons in bone? When you apply a signal to them, what do they do? Not a whole lot. So things that don't move a lot, bone cortex or calcification, they're going to look black on MRI because they don't give you back, they don't line up and then give you back a strong signal. Okay, so then we go over to this fat saturation sequence and we see fluid around the appendix. So then this is our Fiesta sequence. And we see free fluid down in the right paracolic gutter on this sequence. So there's such a large amount of free fluid that you would really have to entertain the diagnosis of perforation and would need to call. Okay, so here's how the restricted diffusion can help us. So on the fat sat, we've got, here's the round appendix that we verified on our T2 single shot fast spin echo. Then we see fluid around. What if we only saw fluid in the appendix and there was no fluid around the appendix? So what do we tell them? We don't need to get, well, what about going to the OR? Can't give you a firm diagnosis of early acute appendicitis without seeing inflammation around the appendix. This could be fluid from the bowel in a normal appendix that does not have the base occluded. So, you know, these guys are trying to make decisions. They have to go back and talk to their attendings and say things that sound reasonable. So, you know, let's try and understand what we're doing, understand the physiology, understand how the physiology affects what we're seeing on our picture, and help them make surgical decisions by, you know, being confident about what we're seeing. No, I don't see any fluid around the appendix. I see fluid in the appendix. I cannot say that this is an early acute appendicitis unless I see inflammation around the appendix, because this could be fluid from the bowel. Everybody feel confident about that? Good. Okay, so on the diffusion weighted imaging, if you have perforated, if the appendix is perforated, it's going to show a greater degree of restricted diffusion. So here's a picture of, here's our T2 single shot fast spin echo. What do we use that sequence for? Shout it out there. T2 fast spin echo. Right, so we're going to use those 3 planes to find out where our appendix is because it's hiding behind the uterus, or we're going to look at the cecal tilt angle and figure out where we're looking for that. So we use the T2 fast spin echo to find the appendix. What do we use the fat sat for? To see if there's fluid and inflammation around the appendix. What are we going to use the diffusion weighted for? So we know we've got an acute appendicitis, right? Because we've got fluid in the appendix, we've got fluid in the tissues around it. So we have an acute appendicitis. So we're going to use the diffusion weighted imaging to help us decide if it's perforated. So if it has a real high signal on the DWI and a profoundly low signal on the ADC map, and for the first years, roughly, the physics are a lot more complicated than this, but roughly on the DWI, anything that's bright will be dark on the ADC map. And what that helps you with is something called T2 shine through. So you kind of have to look at both of them. You look at the DWI, and then if you're concerned that the signal that you're seeing is actually just T2 signal, you can look at the ADC map to help you out. The next 3 times you hear that, it's going to make more sense. Okay, yeah?
So whenever it shows restriction, why is it showing restricted with the perforation and not just the regular?
Usually, in looking at these, usually the area that shows the highest degree of restriction is the perforated tip, the area where it perforates. I'm not sure exactly why, what the physics of that are, but it seems when I've looked at these that the area exactly where it perforates is the area of the greatest restriction. It may have something to do with when you, intra-abdominally, when you get an inflammatory process, the mesentery is kind of an active organ. If you have diverticulitis or you have appendicitis or something that's going on in the abdomen, the mesenterial, it's like this octopus. It'll kind of wander over there and try and clamp itself over whatever's going on. So it may be that you have adherence to this mesentery, and then you have that somehow that restricts the diffusion. That's what I'm thinking. The profoundly low ADC map findings, and they gave, in one of the articles I read, they gave a 7.2 millimeters per second diffusion speed for the cutoff for perforation. Okay, so here is our appendix coming off the base of the cecum. We've got fluid in the appendix and fluid around the appendix. So here we see the base of the appendix, the tip of the appendix, and then we see all this high signal and diffusion weighted. And on the ADC map, that area right there would look really dark. So that's suspicious for perforation. So what does that mean for fetal mortality? Okay. So here's another picture. You can actually sort of see that there's an abscess that's formed here. So the appendix is kind of stuck to the gravid uterus. Out here, this is, remember we were talking about that, where when you have edema that kind of just infiltrates into the fat. So you've got this high signal, but you don't really have a loculated fluid collection. So this is the kind of stuff that if they're asking you, can you drain this? That's not going to drain well. It's not going to drain well surgically. It's not going to drain well through a tube. This, you could probably aspirate to direct antibiotics. And sometimes if you have perforated, if the patient has already perforated, that will then change surgical management. They won't go that day. What they'll do is they'll give them IV antibiotics, and they will wait 2 or 3 weeks, and then they'll go in and do what's called an interval appendectomy. And the reason they do that, if they go in and open this up, they can't close her. She's going to have a Penrose drain sticking out of there for the next 2 months. So if it's important to differentiate between acute appendicitis and perforated appendicitis, because the surgical treatment is different. And the reason why you can sit on a perforated appendix instead of an unperforated appendix is the pressure has been relieved. So in an unperforated appendix, you've got bacterial translocation because of that pressure. So they get septic. Once it perfs, if they're not, septic, then you don't have that high pressure that's driving that bacterial translocation across the appendix wall and sepsis, and then all the attendant problems with blood pressure and everything. So important to recognize perforation because the treatment is different than acute. Okay, so this was a nice picture of a mucocele. So there's a bunch of high signal in there. How can we tell that that's not an appendicitis? Okay, so the wall is thin. The lumen's going to be more distended than you see. This would have perforated if this was an inflammatory process. The reason this hasn't perforated is because it occurs so slowly that the wall has time to accommodate that. So it's got a thin wall. There may be a little bit of calcification. I actually got shown one of these on boards, not on MR, but I'm sure the GI lady was like, oh, I can't wait to show that case. I'm sorry? That's in the differential. It is. So we would use our 3, remember we got the single shot fast spin echo in 3 different planes? So you can, a lot of the times on this, you can see the appendix a lot better on the sagittal in pregnant ladies because the gravid uterus is pushing it up and back. So it seems to show up better on the sagittal. So if you can follow it back to the base of the to the base of the cecum, then you know it's not the ovary, right? Where's the ovary going to be in a pregnant lady? It's not going to move up out like the appendix is, right? It's going to get smashed laterally. Okay, so physiologic. So we looked at it. We've got a normal appendix. So the next thing that we're going to think about is physiologic hydronephrosis. So in pregnant ladies, they have some hormones that kind of relax smooth muscle. It keeps the uterus from contracting. It also keeps the bowel from contracting normally. It keeps the ureters from peristalsing normally, which is why you can kind of get this physiologic mild dilatation. You usually see it on the right side. You can see it bilaterally. It's very important to be able to differentiate between physiologic hydronephrosis and obstructive because they have different treatments. Okay, so for obstructive, we're going to look for that kidney to be larger than the other kidney. We're going to look and see if we have perinephric fluid. If the pressure gets high enough, there's a point in that calyx where it'll burst and fluid will go into the perirenal space, okay? We look for an abrupt change in the caliber of the ureter. If we have physiologic hydronephrosis, we're going to have a smooth tapering at about the pelvic brim because that's where the gravid uterus is compressing the ureter. If we have a stone, we're going to see an abrupt transition right where that stone is. And sometimes you'll see the calculus. Okay, so we've got an enlarged kidney with this renal collecting system is larger than we usually see for physiologic hydronephrosis. Usually physiologic hydronephrosis is mild. You know, this is more than just mild. We've got some perinephric fluid. And then on the sagittal, we can see the ureter coming down, and there's a fairly abrupt transition. It's fat right down to a point. So that's very suspicious for a stone. Okay, so here we have a dilated collecting system, and we're lucky enough to see that calculus right at the UPJ. Here we are on the sagittal. UPJ, collapsed distal ureter. Okay, so here's...
Dr. Wilson, with the obstructive hydronephrosis,
Yeah.
You may discuss it further on in the lecture, but treatment options?
You know, they are tough to perk because you can't put them on their tummy, but I have had to perk some. You?
We're going to put a double J stent there and let the stone pass.
Okay.
When it's that size.
Okay, and
Yeah?
yes, sir. Okay.
So, and you guys remember for sizing calculi, they usually use like 8 millimeters. Is that what they use here?
What's that?
They usually use 8 millimeters.
Yeah, yes.
Yeah? Okay, so when you're looking at axials, remember, you're always going to see the short axis of the stone. So if you really want to give an accurate stone measurement, you've got to look on the sagittals or the coronals, because that number will be important for them when they decide how to manage. So here we see a smoothly tapered ureter right at the point where the gravid uterus is going to compress it against the pelvic brim when that lady's in this recumbent position. Okay, so the most common ovarian mass is a benign cyst, and a benign cyst can be a corpus luteal cyst. So in the first trimester, they can be pretty big because that corpus luteal cyst is responsible for supporting that pregnancy until the placenta can take over. It's got a big job. Okay, it can be a follicular cyst. It can be a hemorrhagic cyst, which is, you know, a cyst that just kind of grew and grew until it distended a capsular vessel and that bled. Or it can be endometriotic. And those will have different signals, and the upper levels and your professors will help you sort of understand the pattern of evolving. Hemorrhage evolves, and it changes on the T2 and T1 signals, and that's another thing that you'll kind of have to learn as a first year, how it doesn't always look the same. It depends on the age of the blood products, what they're going to look like on MRI. Okay, so the most common tumor is a benign cystic teratoma. So here we see a cystic mass. So we knew from the other sequence that this area was cystic. And then we see one that has a high T1. So what is this, what other signal do you see in the body that looks like that nodule? The subcutaneous fat. Okay, so then we do a fat suppression sequence, and what happens to that nodule? So what is it? Okay, so you've got a cystic mass that has a fatty nodule. So that's a cystic teratoma. Okay, so here's another one. So we see the cystic component, and then we see the component that follows subcutaneous fat. And then we could do the fat-sat sequence on that, and that would drop out. Okay, so here's a third example. We see a cystic mass in the pelvis, a little nodule that's following fat on all sequences. Following fat on all sequences. And then, so here's the fat out here. So cystic with a fatty nodule, cystic teratoma. What else? So what else can happen to an ovary that has a cyst or a tumor on it? Okay. So anytime you have an enlarged ovary, like from hyperstimulation, polycystic ovary, or a lead point like a cyst or a mass, it can cause the ovary to twist on its pedicle, which is extremely painful. Okay, so in pregnancy, we have two different things that are going on that make the lady at increased risk for thrombus. There are changes in the clotting cascade, and some of this is to kind of prevent problems with bleeding around the placenta. And some of the forces are mechanical. So you've got changes in your clotting cascade that predispose to not bleeding, and then you've got changes with this, you have this fetus that's sitting right on those iliac veins. Okay, so peaks at 36 weeks, and you also get dilatation of the vein walls from progesterone and relaxin. Those are all those hormones that help the gravid uterus not contract, just help that smooth muscle relax. So here we have a fast spin echo, and we see flow voids in the vessels on the fast spin echo. And on the 2D time of flight, so everything is saturated in that field. And then we see signal in the IVC and the left ovarian vein. So what is the bright signal in the IVC and the left ovarian vein on a time of flight mean? Remember, that's the slab, everything's saturated, and then what happened in the IVC and the left ovarian vein? New blood flowed in to that slab and gave a bright signal. So why are we not getting the signal back from the right ovarian vein? Oh, okay, so there's thrombus in the vein, so there's no new blood flowing in, right? Awesome. Okay, so here as you look at these, you'll sort of get a feel for this too. Usually an ovarian vein is not bigger than about 7 millimeters, so this is just a very enlarged right ovarian vein, and that can give a typical kind of achy varicose type pain. It's not thrombose, but it may be the cause of her pain. Okay.
Whenever you have someone who's pregnant like this, can you still call like pelvic congestion syndrome?
I would be really careful about calling that during pregnancy. I would wait 6 months or a year after and see what it looks like, because you don't want to go in and embolize somebody based on what you see. Everything is dilated and it's not good. Yeah, don't go there. But after they're delivered, if they still are having that kind of pain, because what happens, like venous disease is like a self-fulfilling prophecy. So you have these valves, venous valves that prevent backflow of blood. So if you relax the vein and these valves don't coapt, and then you get a little bit of reflux, then what happens is the vein dilates further. There's less coaptation of the valves, then it dilates further. So that may never go back. It may and it may not. But that's how venous disease tends to act. Like once water gets through that gap, it's just gonna make itself worse. Oh, okay, so here, this was a nice picture. You can see the vascular pedicle of that ovary, and you can actually see the vessels twisting in that pedicle, and then you see this grossly abnormal ovary. A lot of the times you'll see fluid around the ovary. You'll see the follicles, they kind of line up around the capsule of the ovary in this characteristic distribution. Okay, so here's another enlarged edematous ovary. Here we see the appendix and the cecum that's kind of smashed. And then when we look at the sagittal, the sagittals I find really helpful in pregnant women. It must be because of the way things move around, but you tend to see a lot of stuff on the sagittals that you have trouble appreciating in the other views. But you could see this twisted vascular pedicle sitting on top of that edematous ovary. Okay, so here is an infertility patient with an early intrauterine pregnancy, and then she has big cysts on both sides of the ovaries. So she's got ovarian hyperstimulation. So this is what remember we were talking about our algorithm at the beginning. Like we need to anticipate what's going on with this patient. So the next thing that we want to know, if we have bilateral enlarged hyperstimulated ovaries, the next thing we want to check, is there any fluid in the abdomen? Is there any fluid in the chest? Because if there is, then she needs to get admitted. And then also you've got an abnormal ovary, so you're going to look for torsion. So like have this going in your mind. You know, if I see this, I also need to look for this. Okay, so now we're getting into the weirder cases, but I thought it was kind of fun. So here we have a pregnant lady, and here's her uterus, and here's her endometrial canal. So if you have a pregnant lady, she's got a positive pregnancy test, and she doesn't have anything in her uterus, what do we have to worry about? Okay, so on ultrasound we know that. If we've got a positive pregnancy test and there's nothing in the uterus, it's got to be somewhere, right? Okay, so we see this cystic area over in the adnexa, and we see this little tiny structure that measures about 6 millimeters from outer wall to outer wall. What's that? Okay, and then we see these areas of hemorrhage. So we have a gestational sac and a fallopian tube with areas of hemorrhage. Okay, so here was another one. You can clearly see that this is the uterus. Here's junctional zone. Here's the endometrial canal, and we've got this big mass. So you've got to be worried. Pregnant lady, and it's not in the uterus. You've got to be worried about an ectopic. Okay, so this one, they were unable to call this on ultrasound. They saw a big placenta, but couldn't account for the lady's pain. So on MRI, we've got a fluid collection between the myometrium and the placenta. What's that? Huh? What? Yeah, it's a placental abruption. So you've got a subchorionic hematoma. Okay, so here's another one. Got it on ultrasound. All they saw was a great big placenta, but we see these fluid levels between the chorionic plate of the placenta. So the chorionic plate of the placenta is the portion of the placenta that adheres to the wall. So if you see something between the chorionic plate of the placenta and the myometrium, that's abnormal. Okay, so here we see placental tissue all the way down to the bladder wall. So what should we see between the bladder wall and the placenta? What should we see between the chorionic plate of the placenta and the bladder wall? Right, myometrium. Okay, so this is a lady who had had a prior C-section, and you see discontinuity of the lower segment, the anterior uterine wall. So this was rupture and hemoperitoneum, and they lost that fetus. Okay, so she's got a fibroid. Here's her uterus. Here's the endometrial canal. Here's an exophytic subserosal fibroid that showed restricted diffusion on DWI, so you know there's acute edema. So if the fibroid is undergoing degeneration, that can be a source of significant pain. Here's another degenerating leiomyoma. So on the T2 fat sat, we see high signal in there. What does that mean? So we've saturated the fat, and we're still seeing high signal. So what is it? Edema. It's edema in the leiomyoma. Should the leiomyoma normally have edema? No. Okay. So Crohn's is becoming more common in the population in general. So you have to think about something like this. Somebody's got abdominal pain. You've looked at the appendix, it's normal. You looked at the kidney, it's physiologic hydronephrosis. You looked at the gallbladder, there's no gallstones. You looked at the uterus, the baby's inside the uterus where it should be. So now you're looking at the bowel and you're like, well, there's fluid around the bowel and I've got mural thickening and mural edema. So it's in the part of the bowel that's near the cecum. So Crohn's would be a good differential for that. And that's important to recognize because that's not surgical, right? They try and stay out of the abdomen as much as they possibly can in Crohn's. Okay. Unusual. Usually you don't see diverticulitis in this age group, but mothers are getting older and low fiber diets are very popular in northern Louisiana. So you can see the diverticulae on the single shot fast spin echo, and then you can see fluid in the left paracolic gutter. So if you saw that on CT, you'd know what it was, right? Right? If you saw diverticulae with fluid on CT, you'd know what it was, right? So when you see it on MR, you're going to recognize it, right? Okay. So this lady had a stone in her distal common bile duct, and the common bile duct is markedly dilated. So we've done a fat sat. See how gray the fat looks? See how gray this, and we've got a little bit of inhomogeneous fat saturation, but still, it's kind of grayed out. So we see some high signal anterior and posterior to the tail of the pancreas. Should that be there? No, what's that? Huh? So what's the pathophysiology here? We've got a gallstone. Why do we have pancreatitis? Okay, so the configuration of this patient's ducts are such that the distal stone is also obstructing the pancreatic duct. Okay, so this was an important point that they brought out many times in the literature. If you have edema in the wall of the gallbladder, do not call acute cholecystitis. If you have pericholecystic fluid, you can call it. So if you see kind of a thickened wall with some mural edema, pregnant ladies have edema in lots of places. They have it in their gallbladder wall. So if you're going to give them a diagnosis of cholecystitis, make sure that you can demonstrate some pericholecystic fluid. Okay, so if you're looking at a mass, an ovarian mass, and you're wondering, if this is the benign cyst that we were talking about earlier, that's the most common ovarian mass, the things that you're going to look for to help you decide that this is not just a benign cyst: nodules, mural nodules, numerous septations, thick septations, a mass that demonstrates necrosis. Why do cancers like to demonstrate necrosis? Exactly. Okay. And peritoneal metastases. Okay. And this is another really weirdo case. So this was a preeclamptic patient, and this scan showed edema in her liver, pleural effusions, and ascites, and it was health. This is very unusual, but sometimes if you've seen something once, then the next time when you see it, something rings a bell. So I try and show a lot of cases so that bells will be ringing. Okay, and this was a super weird case. She had an ectopic pregnancy in the interstitial portion of the tube. So you've got the fallopian tube, and it comes to the uterus, and when it goes through the wall, that's the interstitial portion. So she had an ectopic pregnancy there, and it actually ruptured the uterus, and when they opened her, they saw this free-floating amniotic sac in the abdomen. So, after you've gone through your whole list of the things that it could be, that are more common, then you start looking, what are the other things that happen in pregnant ladies? Ectopic pregnancy, all those sorts of things. Okay, so these are the take-home points. Acute appendicitis is the most common reason that these ladies are going to have to go to the OR. Find the appendix on the T2 fast spin echo 3 plane. Find the appendix. Look at the fat sat. Is there edema around the appendix? If there's not, your appendix is normal. Even if it's 13 millimeters, it's normal. Remember, size doesn't matter on CT and MR. Use that in ultrasound, but on CT and MR, you want to use your edema around the position of the appendiculus and periappendiceal edema to help you. So then you go on to the kidney. Most of them have hydronephrosis. We've got to sort out whether it's a hydronephrosis that's causing the patient's pain. If it looks like it's physiologic hydronephrosis, look at the gallbladder. Then you look at the ovaries. Then you look at the pancreas. Just keep going to the less common things. So start with the most common and go to the least common. Okay. That's it.